Good day, everyone, and welcome to another installment of what we hope will be a very useful series of short informational videos really centered on clinical trial operations, execution, and kind of how you run a clinical trials enterprise at your site. I'm Dr. Kathleen Moore. I have the great honor of serving as Associate Director of GOG Partners, and I'm a GYN oncologist at the Stevenson Cancer Center in Oklahoma City, and I'm joined by my very good friend, longtime friend, Dr. Tashana Myers, who is the division chief at Bay State, where she's been since 2009. And so we're going to have I think, a very helpful conversation today. Dr. Myers, welcome.
Thank you for having me. Excited to be here.
Yes, we were just joking a little bit off air that we actually trained together, and Dr. Myers is my first fellow, although yes. I think she taught me more than I taught her. So that's a whole podcast in and of itself. So let's get into the topic at hand, because what we really wanted to talk about, and we talked about this ahead of time. I'm just going to call you Tashana, and you can call me Katie because we're friends. And why we're doing this is really trying to help provide some little nuggets, as I like to say, of thought for all of the GYN oncologists out there who are trying to start their own site or grow their sites, and really interview folks like you who have built very successful clinical trial programs in different sorts of settings. And so you're at a smaller academic institution. So I wanted to just start with that. When you came in 2009, now it's 2021, what did you walk into, and how did you build the very successful program you now have?
Absolutely. So when I started, we were an affiliate of a larger institution. We essentially did the minimum. So we had a minimum of 3 patients we needed to enroll each year, and we just made that minimum, and then that was it. And so that was the culture I walked in, is that our goal every year is 3. I trained at the University of Oklahoma, where there was no goal. I mean, the goal was every woman goes on a study. And so I was very clear when I took this job that was one of the things that I wanted to accomplish. And so essentially what my first mission is how do I become a primary site? And that's sort of old lingo now. That was a different model than we were under. But that was still sort of in my mind. To be a primary site, you needed a certain number of points. I knew how many patients we had, and I felt like that was a reasonable target. And we were actually able to accomplish that within 2 years. And really, we enrolled more patients than our primary institution. And so they were like, yeah, I think you're ready to be all grown up.
So let's branch off of that. So you're right. We are talking about sort of legacy GOG points, and things have changed, and things really changed even at our site, in Oklahoma, where I still am, in the 2014-15 era, when the cooperative group got a little less, less trials, and really we all shifted to really being kind of a combined pharmaceutical company GOG sort of mix. So with that transition, as you were still growing, how do you kind of select studies? How did you integrate the clinical trial culture that you talked about that was a cooperative group culture? How did you grow that culture as you diversified into the kind of pharmaceutical and cooperative group worlds?
So what I realized was imperative was to be a very present PI. I needed to understand the process of how I went from a GOG or NRG meeting and decided I wanted a study opened to how that actually happened at my institution. I always brought my research associate with me to the meetings, because I thought it was important for, in real time, she and I to sort of build what the studies were that we wanted. And then I needed to know who the people on the IRB were. I needed to know how money was handled in our institution. I needed to know who reviewed contracts. And so I began to set up a series of meetings. So within a few months of me being here, I sort of introduced myself. I'm a clinical trialist. This is my personal goal. This is the need for our institution. And I just want to learn sort of how you help me to do that. And so it became one of those things that I wasn't just sending it to a department. I had a name of a person that I could say, hey, this contract got sent to you 2 weeks ago. I'm just trying to get some feedback, Susan, about what the status is. And so my level of interest and involvement, I think, was new for the institution. And so some people were a little not ready for that, and other people were very engaged by it. The other thing is I needed to know how much work was happening in other areas of cancer research. So what was cancer looking like? What was the environment of cancer? And again, we were sort of average performers. We participated in all the large cooperative groups, but we were never hitting it out of the park. And so I had to sit with the PIs and really say, as a group, what do we want cancer care to look like at our institution? Do we want to be the referral center, or do we want to be the biggest community practice? And so I think they began to think about it differently. I think they began to see this brand new fellow who came out and put, 10 times as many patients. And it did. It sort of upped the ante in cancer. And we started to think about how do we collaborate more so that it's not just GYN oncology that's growing, but our cancer is growing, cancer research is growing, and how do we tap into sharing resources? So that was, one of the things that we did, I think, in terms of just getting the nuts and bolts of your program started, is understanding who the key players are, understanding what your staffing is. So my first study was a specimen study. And so that requires people to collect specimens, spin blood. And so do we have bodies to do that? Where would that happen? Really getting into the nitty gritty of how does the study happen? How does tissue get stored? Do we have a -80 freezer? And learning that, I think, also gave value to the team, because they said, well, she's the PI and she actually wants to know what we're doing. It isn't just here, get it done. And I think that helped me to build a program. And then we set up monthly meetings. How many patients do we have on study? What's the status of our current enrollments? And what is our goal? Putting that goal up almost like a vision board to say, we need to get this study. I'll be honest, my first study was GOG 252. It took me 12 months to get it through the IRB. Blood, sweat, and tears. But fast forward 10 years later, I'm an author on that paper, and it was absolutely worth it. But it was, explaining to the IRB, this is an NCI study. We're not changing the commas. We're not adding,
Right.
This has been vetted. The science is solid, and we need to be able to move past that. So there were definitely some hurdles in the beginning. Now I can say my turnaround times are within 4 to 6 weeks.
Yeah, and I think these 10-minute talks are going to be so hard because there's just a lot to unpack in what you just said. But I'm going to reflect on some of our earlier conversations. There's some key points I think you just made that people need to hear. One is you have to know your institution. And you told me this, and I like this term. You have to know the language of your institution. So if you live in the bubble of GYN oncology where everything is great and everyone's on the same page, but your institution is not, and you don't understand what happens outside of your bubble, you can get into trouble. And so really taking the time, if you really are committed to doing this and doing exactly what you said, who handles the contracts, who are your regulatory people? Where do your patients get infused? Does your infusion center understand research? Are they going to understand the difference between a trial order and standard of care? Because they may be a little different and they got to follow the trial order. Are they going to catch that? And if not, how do you train them? You mentioned tissue study. I've gotten caught in those too. I'm like, yeah, tissue study, that's amazing. We're going to put 100 people on. Well, guess what? If you put 100 people, you have to put the data in for 100 people.
Correct.
You got to have the data team. Those people work hard.
Correct.
Don't ever doubt it. So you got to know your institution. I think that's such a critical point that you just made. And then I think it's also a little bit mentorship, because you made a comment about GOG 252 and troubles with IRBs, which I think has largely gone away because we can use CIRB now. And so those kind of nitpicks about, we don't like the bullet point here and we want this in this format. And you're like, well, it's an NCI consent, is largely gone. But you heard us saying that all the time, pushing back, going, we're not going to change the consent. It's an NCI consent. You're not going to make it better. All you're going to do is make it worse. So stop the nonsense. And then they would be like, okay. So I think that, but even though that issue is maybe resolved, kind of asking for help. If you're stuck and something's taking a year, who are your mentors? And that's what we're trying to do with these videos too, is kind of create a network of folks that have been there, done it. You know, you and I talked, and maybe in the last minute or so, you can talk about kind of other mistakes. We've made them all. We don't want you to make them. So kind of talk to us. But what would you say in terms of, you know, you've talked to me about a few things like that you would do differently?
So I think when I first came out, I wanted to be OU, right? So I came from a place with 7 GYN oncologists, a fellowship, 20 years of history, and I was one of 2 people with 1 research assistant and 24 residents, and I wanted to be OU, and I wanted it tomorrow. And so I wanted to open every study in every disease site because that was what I was used to. If there was one woman who was going to be eligible, I wanted to have that study open. And so, you know, I happen to live in an area where GTD is not that common. I opened that GT study. I was proud of myself. I got it open in record time. 2 years, I never saw a patient who was eligible. And, you know, it was my institutional language was, what are good investments in research? Good investments are studies that you open and that you recruit. And just having it for the possible woman that may walk in wasn't how they wanted to how to spend their resources.
Absolutely.
And so that was tough because I know that there's someone who's going to have GTD. It's going to happen. You know, we serve half of the state, and I may not have something for her, but I had to sort of step back and say, okay, who do I see? I see a lot of ovarian cancer. I see a lot of endometrial cancer. And at that point, I had to be strategic about what I opened because I don't have unlimited resources. I don't have the ability to open that study for one patient. And it actually has been great because your success that you build on the things that you know you have allow you the luxury of then opening other things. So I made sure I opened phase 3s because those take longer to recruit. Those give you more time to open. And then once my foundation was set, I went to phase 2s. And, you know, I'm now tapping into smaller diseases, rarer disease types. And I think, but it comes with time and you have to understand, again, know where you're starting, know what your institution prioritizes. And I was at a situation where I'd never been before where they asked me to close a study. And I pushed back and that woman's probably, you know, registering in my practice right now and I won't have a study. And but if it was about which study if I was only going to have 2, I was going to have one in ovarian, I was going to have one in endometrial, and I was not going to have GTD. So but you know, we have ways of getting that particular patient to a GTD study. And so
Absolutely.
I think it's one of those things that, you know, you can help the person that's right in front of you, or you can help women in general with cancer. And thinking broader, it's not just the study I open, it's getting that woman connected to a study in my area that someone else may have open.
Absolutely. I think it's just practicality and kind of being successful where you are and growing. So I think that with those final words, I can't even add to that. So I'm going to just stop us here because it's a little time limited, but we may pick up some of these in a later little podcast. So with that, I'm going to thank my guest and my friend, Dr. Myers. Thank you for taking time out of your morning to chat with me.
Thank you, Katie.
I can't wait to see you in person. And thanks for joining and watching this. And if you find it helpful, let us know. Send us ideas for other little conversations you'd like to see. And we'll keep trying to meet the needs of our members with these little educational snippets. Thank you and have a great day. Thanks, Dr. Myers.
Thank you, Dr. Moore. Bye-bye.
Bye.